couple minutes if you want. If there are other things you want to communicate to the panel, whatever you want.
Oh no, I was just going to say, for the purposes of efficiency for the panels, if we could have the military and civilian sector speakers up at the table all together, and then the Q&A period is actually with all four panelists at once. Yes.
Okay, good. So we've asked Adel to facilitate this next workshop, and it's all yours.
So we'll ask the members of the panel to join Dr. Nathans and Mr. Barnes. Are you in the room? So thank you so much for Dr. Berwick for agreeing to have this workshop on data, trauma data and information systems. This is thought to be a particularly important workshop, given the fact that we're trying to determine how to do a better learning healthcare system, and of course, the key component for that is data. We'll have a joint civilian and military panel, and just to briefly explain who we asked to come, and you kindly agreed, is starting on the right, Ms. Marion Spott, who was one of the first trauma directors for the joint trauma system, and really is known to have built the trauma registry system for the military. Next to her is retired Colonel Brian Eastridge, who was one of the first directors of the joint theater trauma system and helped really build the trauma system the way it started, especially in the Iraq theater. And the next to him is Dr. Avery Nathans. Apart from being a chair of surgery in Canada, Dr. Nathans runs the Trauma Quality Improvement Program at the American College of Surgeons and is all knowing of civilian data. And then following that is Mr. Mark Barnes, who is going to give us the perspective of human research protection and issues with managing the data from that angle. So we'll start with our military colleagues.
My slides, please. You don't have the slides? Okay. So I just wanted to start out with the trauma system is separate from the database in terms of they're not one and the same. So the database is within the organization, and people sometimes confuse that with us. Our registry is not the medical record. We use a lot of interpretive data and not as many as discrete data points, because we have so many different fields and different sources from where we get our data. So we have a variety of forms. We use the medical record as well as several other military databases that have injury information, transport information, as well as the vitals and outcomes data. We had a team of experts, nurses and physicians that went into theater in Iraq and Afghanistan for us. Those teams stopped in December of 14, so our data is captured now back at our central site in San Antonio. In terms of the trauma system, the patient can have up to 10 transfers and transports, and they go along the continuum of care, and as they're going through that continuum, our registry staff are picking up each of those levels of care and binding them into one record. So we have a continuum care sheet that allows us to see all the dates, all the times, all the interventions that each of the patients has gone through at the different levels of care. From that, we have several specialty modules that we've developed, orthopedics, infectious disease, TBI, hearing, vision, and those are integrated with the Department of Defense Trauma Registry, and data are automatically ported from that high-level system into each of the specialty modules, and then finite information is captured on each of those patients in those databases. Not only is it the first combat registry that has been collecting data on the battlefield, but this is the first time that I'm aware of that there is an integrated registry as well. So I don't know if there's one in the civilian community, but my understanding is there is not at this time. The slides that were shown by General Robb and Dr. Smith showed the case fatality rate, and it proves what a trauma system can do, and the data are so critical to support that mission. One of the things that we haven't really shown very well, however, is that we don't know how many people we prevented from being counted in the system, because our procedures and policies and care has been so good that we haven't been able to capture those patients, where the ones that qualify for the database are very well known. We have a continuous operational cycle, so we put data into the trauma registry, we do a lot of data analysis. That goes into our performance improvement section. Those data are then used to develop our clinical practice guidelines, which we put out to the public forum on a public website. There are approximately 42 of those. They range from hypothermia to damage control resuscitation, and they are guidelines. They are not policies that must be followed. So it allows for more standardization of care without saying you should do this or you have to do that. We monitor those processes in our clinical practice guidelines, so there are metrics within each guideline that allow us to see the effectiveness of the guideline. We have a number of challenges still. We started really collecting the data in a consistent manner on a consistent platform with standard data definitions back in September of 2007. There had previously been a database, but it was truly just putting out numbers. It wasn't analyzing the information or attributing factors to anything. It was just a blunt tool to show demographics. But some of the challenges that we have are that we are still not anchored in doctrine. There's no policy that states that we have to have a trauma system. Therefore, it's not integrated into all of the units. So our experience has been mainly based on the CENTCOM area of operations. So the different sections or COCOMs such as PACOM or AFRICOM that were brought up before are not participating in our system. They are not using our clinical practice guidelines. So the chart that you saw with the case fatality rate, where we're doing such a great job, we're going to start seeing those lines come back together again because those practices aren't in place and we can't measure them. We have poor Rule 2 documentation, so anything before a fixed facility has been voluntarily sent to us by people that believe in what we're doing, and it's a coalition of the willing. So they are providing us data. Pre-hospital data as well is very small to trickle in. It's not in policy that we have to have that, so we don't always get to see it. Our TC3 guidelines that you'll be hearing about later are not standard across the DoD. Most of the lessons that we have learned, so when we moved from Iraq into Afghanistan and started looking back at some of the Iraq patients that are coming in, those lessons were lost and those patients had devastating injuries that could have been prevented. We have no integration with our Armed Forces Medical Examiner's Office. While we do have a monthly or bi-monthly conference with them to review all the autopsies and some of the injuries that the patients have been attributed, we have no direct interface with them in terms of sharing data. So it's a collaborative collegial arrangement, but nothing in writing. We have no VA data access or integration at this time either, so the long-term outcomes are not readily available to us, and we would like to see what the long-term effects of some of the treatments are, but that does not exist at this time. We have, as I mentioned, the specialty modules. They're not being used. That is partly a resource issue and partly a political issue. So we do have some data in terms of infectious disease and orthopedics, and we're trying to do our first integrated registry paper. However, it's not completely supported across the DoD. We have a very difficult time sharing our data across federal entities and private entities. So sharing with our civilian counterparts is very difficult to us. And we are looking at constant ways of staying relevant, especially in the peacetime periods. We are very relevant certainly during the wartime period, but as we're all here today to discuss the translation piece, that's where we're really trying to make effective change. We have a lot of external advocates that are wonderful to us and are helping shape and mold our future. But a lot of times those things don't come with resources. So the great ideas are great ideas for a long time. And we're constantly challenged with trying to get people to understand what we do, why we're important, and the value of the outcome. Because again, we can't tell them how many people we prevented from coming into the system in the first place. Thank you.
Thank you very much, Ms. Spott. Just to remind the speakers, there is a 7-minute limit to talking, and at around 5 minutes or so, I'm going to put my card up to give you a warning. Also, before you speak, Dr. Eastridge, just a point of clarification. Is the registry data linked to the hospital medical record, not to the VA? We know that, you mentioned that. But what about the medical record at Launch Dual or Brooke Army?
They're disconnected systems.
So I will also be talking about some of the other...
Can you turn your microphone on?
I'll also be talking about some of the other implicit challenges and values for data and data utilization analysis from a system perspective. You can go to the next slide. And the next slide. So again, the value of data really can't be underscored. And when we started off building the trauma system, even in the explicit underpinnings of the mission of the trauma system, many of the mission components were salient to the utility of collection of battlefield data and the ultimate idea that the data would be used for performance improvement activities, as well as ultimately responsibly used for research activities. Next slide. So the registry development, when we first developed the Joint Theater Trauma Registry, which is subsequently morphed into the DoD Trauma Registry, we built it based upon the contemporary standards of EMS and the National Trauma Data Bank. And we did this for a very simple reason, is that we wanted to be able to apply lessons learned and more easily translate lessons learned from the battlefield to the civilian environment, and then subsequently back from the civilian environment into the military environment. And to do that, we needed to apply same data fields, same basic data collection techniques to accomplish that part of our task. Next slide. So the system, you can see there are numerous components to the way we built our system. And again, we built our system on a template of regional trauma systems in the United States, specifically one of the ones in South Texas, because that's where our Level 1 Trauma Center was. But central to all of our components were information systems. Information systems really drive all of the other components with respect to, particularly with respect to performance improvement activities, hospital activities. It drives our ability to, drove our ability to communicate with medical and line leadership about contemporary, near real-time medical issues on the battlefield. It also, subsequently, we were able to, once we developed a significant compendium of data, we actually used that data for research activities, and many of those research activities have had profound effect on the way we take care of civilian trauma patients. Next slide. There are, however, some registry and data liabilities that we encountered. There were several areas where we had required access but relatively limited access, including the pre-hospital environment. A lot of this is driven by the operational context, where our medics and our corpsmen really don't have the time to actually document pre-hospital care. And certainly on the back end, Ms. Spott already alluded to the issues with the level 2s and that continuum of care, but also we have issues with back end documentation, particularly after troops leave their immediate or acute resuscitative facilities, whether to go into convalescent facilities, rehab facilities, the VA, or back into the civilian environment, they are effectively lost to the data stream. Again, the data is vitally necessary so that we can drive combat casualty care development. We can also evaluate the burden of injury with respect to mission capability and other things like quality of life for our troops that are injured. Next slide. Also, from the perspective of liabilities, the data comes from, the data that we need comes from the Tactical Combat Casualty Care card, the VA and non-integrated CONUS medical treatment facilities, and other civilian facilities. Again, there's a number of barriers to collection and sharing of data across the components. There's some successes. You know, having the CENTCOM surgeon, the Joint Staff Surgeon, was really to drive and be advocates for the trauma system and for data utilization, was basically pivotal to being able to advance the trauma system. But some of the issues and barriers we came up against were the line command emphasis, which has been alluded to earlier. Again, things don't happen on the battlefield unless the line commander says they happen. Ms. Spott has already alluded to the critical deficits in data linkages across the continuum of care, and there are many regulatory issues that we faced, particular challenges, not the least of which was the perceived competition with the electronic health care record, and actually having to drive home the point that we were not an electronic health care record, but actually an abstracted component to be utilized for performance improvement and research activities. Next slide. Some of the unique challenges, or actually maybe not unique challenges, were data fidelity and standard data audits. We did those effectively during the mid part of the war when we were really effectively resourced. But again, as our resourcing dropped, we found our ability to maintain that data integrity, that granularity of data, and to do routine audits actually was significantly diminished. Again, the linkages were significant issues, and the linkages that Ms. Spott alluded to, a lot of the linkages we were able to develop were developed basically post hoc, sort of as on an as-needed basis and not in a streamlined, methodical fashion. Next slide. So what are the values of having this data? Having this data clearly from all the activities that the data supports, particularly the performance improvement, the education and training aspects, is clearly an iterative process. The more we know, the more we learn from the data, the better we get at doing things. The trauma system leadership and our subject matter experts routinely use this data to inform their line commanders, their medical commands about important medical issues on the battlefield. And again, the data fosters a near real-time acquisition of data for subsequent data analysis, particular for performance improvement activities. And again, many of those performance improvement activities have been illustrated in some of our clinical practice guidelines. And again, about 60% of our clinical practice guidelines, of which we have about 40 now, about 60% of those are evidence-based with contemporary evidence from the battlefield. And the other thing is that the real-time advisory capacity to the COCOMs, the liability there is, again, not all COCOMs are involved in the system. CENTCOM was intimately engaged in the process, but the other COCOMs, again, because they're not actively engaged, haven't really bought into the idea of a trauma system. Again, there's numerous barriers that we can probably talk about more specifically, not the least of which are regulatory barriers when it comes to research, and also barriers when it comes to confidentiality and competition with the electronic healthcare record.
Thank you very much, Dr. Eastridge. We'll move on to the civilian discussion, and then we'll take discussion right after that. So, Dr. Nathans.
Well, thanks. Again, it's a privilege to present in front of such an eminent group. I'm going to start with my slides coming up.
So that looks like my slides.
Yeah. Next slide, please. Oh. So I'm going to go first and outline what the current state is with the American College of Surgeons Trauma Quality Improvement Program. Current state is we have about 320 hospitals that are contributing data through over 1,600 registrars across the country. And these registrars abstract roughly about 150 data fields that are well described in the National Trauma Data Standard. And this data standard really prescribes precisely how the data is to be collected, where in the medical record it should be found, and what validation checks typically would occur upon submitting the data, so that you can't submit dates and times that are incorrect or out of range, ages that are out of range, and so on. So it actually prevents you from entering incorrect data. You'll see that the data fields that we collect are primarily around the acute phase of care, so they all relate to the initial index hospitalization for trauma. There's a small amount of information we collect about facilities, so bed size, types of docs in the facilities, maybe a little bit about the structure of their trauma program. When we want a little bit more granular data on a particular area, we actually survey the centers. We have roughly one survey a year to get a little bit more information about what the processes of care or the structures of care are in our participating centers. The current state is very different than the recent past. So the National Trauma Data Standard just came to light in 2007. Before that, there was no data standardization. With TQIP, we developed an education program for our 1,600 plus registrars. Before that, which was before 2010, there was actually no comprehensive education ensuring that the registrars would collect data the same way. So that allowed TQIP to move forward. Oops. So the data that we have is certainly not all that we need. We have significant challenges with pre-hospital data. So if you look at our ED admission vital signs, for example, maybe we have 1 or 2% missing data. When we look at pre-hospital vital signs, we have 20 to 30% missing data. It's very difficult to assess the quality of pre-hospital care or how that might impact on ultimate trajectory of the patient while in the hospital and their ultimate outcome. So we really don't have that piece well covered yet. We have no surgeon identifiers, which is great because we look at the system within the center itself, but it doesn't allow the surgeons to understand how they compare to other surgeons. So surgeon-level benchmarking isn't possible, which limits the possibility of using our data for maintenance of certification and PQRS. We have no long-term outcome data. We have actually no data post-discharge, which is very problematic, and I'll highlight that a little bit later. We have no understanding of how rehab care is delivered, who has access to rehab care, and how the quality of rehab care impacts on later functional outcomes. So a big gap there. And we have no financial data. Financial data typically at the hospital level is sequestered in a different data system, and it might be linked at the hospital level, but it certainly doesn't come to us. So that leads to problems in ultimately deciding on the preferred strategy for care when you're looking at, when you don't have information about costs. So those are some of our critical data needs. What has been successful, I think what really allowed us to move forward with developing a benchmarking program and a quality improvement program, before it was just a database, was implementing the National Trauma Data Standard. And this, I think, probably took 2 years to develop. A lot of stakeholders involved. Stakeholders were certainly beyond the acute care environment. There were a number of individuals involved from a public health perspective who were interested in injury surveillance. There was pre-hospital care providers, not many post-acute care providers involved, which is why we have that gap. But it truly enabled TQIP. It also allowed us to standardize a collection across centers, which allowed us to go through the HL7 process to become the trauma CDA. And now the NTDS is the normative standard, which allows interoperability with EMRs. So this allows us to move forward now in extracting data from the electronic medical record. The other big success we had was learning how to educate the people so important in collecting the data. Without that education, then there was no possible way of benchmarking across centers. There just was no means of standardizing. And you know what most registrars were doing, they were doing what they were taught by the previous registrar, or they were doing precisely what the trauma medical director told them to do, which isn't a good means of standardizing. Another success was developing a series of best practice guidelines that evolved from looking at our own data. So in many areas, we saw there was significant variability across centers or significant gaps in understanding how care was delivered. And we focused our initial best practices guidelines on trying to provide information to the participants on those particular areas. So examples might be, we have a geriatric trauma guidelines. We did this because there was a significant gap between hospitals' quality of care for young patients versus elderly patients. Hospitals that were really good at taking care of young patients were not so good at taking care of elderly patients. There was a big gap there. Working with Dr. Spinella and Dr. Holcomb, we actually developed a best practices guideline in massive transfusion. There was a lot of confusion about how to put together an MTP protocol. There was confusion about how to use ROTEM and TAG, how to deal with the novel anticoagulants. So this actually allowed the centers to figure out what they should be doing and how they have to measure what they're doing with respect to massive transfusion. We also noticed significant gaps in the management of traumatic brain injury. So we convened a panel with neurosurgeons, neurointensivists to come up with guidelines that would help define how these patients should be taken care of. And this really, I think, is going to change and move the bar for the patients, for the care of patients with traumatic brain injury. Ongoing challenges. So we have no post-discharge outcomes. We have no health-related quality of life, EQ5 and SF12 being some very basic measures we don't have. We don't have anything about functional status, return to work. We know nothing about pain and mental health outcomes, which are significant factors that prevent return to work. And the barriers to this are HR. I mean, there's just not enough human resources. Hospitals can't afford to hire people to get post-discharge data. Also, post-discharge follow-up is very challenging. In NSCOT, and Ellen probably knows this very well, it's challenging. You have to invest a lot of money in finding these patients, even as far as a year out. You lose about 40–50% of patients. And if you decentralize the data collection for post-acute care and you're trying to do all these instruments, you really need to standardize this across centers. And the best way to do this is probably centralizing it somewhere. The state of Victoria in Australia has figured this out, and they have a wonderful program run by Belinda Gabby, and she's been managed to following patients for 2 years, a whole series of quality of life outcomes, but she's been successful because it's been standardized and centralized. Also, we can't assess value of care without getting costs, so it's a significant challenge understanding the value of the care we provide. The trauma medical directors have too much data. And the data they receive, they can't necessarily follow through on understanding what they have to do at the hospital level. They're good trauma surgeons, but affecting change is a whole different thing. We need to develop a coaching program around them, much like Hopkins has in SUSP and CUSP, to teach them how to use the data and to allow them to work as part of a larger collaborative. Opportunities for improvement. So we need to standardize at the front end. Now we deal with multiple vendors. Making a change at the front end where the registrars enter the data is a major challenge because we have to deal with many vendors. We need a standardized follow-up interval. So we just follow patients to discharge, not even to 30 days. So if you're discharging a patient to hospice and they die in hospice, we won't know that necessarily. We need identifiers to allow for linkage to pre-hospital data, so NEMSIS is a perfect example, and cost data, CMS. We don't think this is a HIPAA issue. This is probably an issue with our business associate agreements with the centers. We need to extract data from EMRs. Certainly going through the HL7 process has been helpful. Structured data will come to us through the EMRs relatively easily. Unstructured data, particularly complication-related data, will probably take some more time. We need means of natural language processing to actually extract from text complication outcomes. And we need to lessen the burden of in-hospital data collection so we can actually get the fields we can't get through the medical record. And that concludes my talk. Thank you.
Thank you so much, Dr. Nathans. So we've heard a lot about the data and now the challenges with regulatory issues and human subjects protections. Mr. Barnes.
Yeah, thank you very much. I think the reason that I was asked to talk today is because there is widely perceived and widely experienced there are a number of the legal concepts and the legal restrictions, the regulations, the HIPAA regulations, and other kinds of regulations stand in the way of developing a real learning system across institutions. It's quite easy to do it really within one institution or within like Kaiser, for example, which follows people through rehab and in the pre-hospital space as well. And so it's one unified system and it can use its data in any way that it wants to use its own data. It can crunch them, it can run them, it can do real-time addition to databases. But when one has both a when one has multiple institutions involved at multiple levels of care. And then in this case, I believe that one of the challenges for the military trauma system is that you have individuals who are part of the DoD defense system care facilities, but then they also are interacting with private facilities as well, either before or after, and along the way as well. And so the question is, how do you build a learning system in that way, and how do you overcome the legal barriers? The legal barriers can be overcome, but one of the problems has been that we have this very complex, as all of you who are in healthcare know, we have a very complex system of privacy regulations that were adopted in the last days of the Clinton administration, and therefore have been in effect for about 15 years. And these regulations, the so-called HIPAA regulations, they are incredibly prescriptive in the way that they allow us to handle medical information. And I'm agnostic for the purpose of this presentation as to whether that's good or bad. It's just the way it is. But as I think all of you know who have run hospitals before, and I have run a hospital. I was the chief operating officer of St. Jude Children's Research Hospital in Memphis for a couple of years. When one has a complex system of regulation imposed on one, the easiest thing to do is to say no, right? Because the default tends to be not to act rather than to act. And so when one gets, for example, as an independent provider, whether you're a community mental health agency or a rehab facility or a tertiary care hospital or a community hospital or anything else, and you're approached by some entity from outside that you don't know well, and there's no one at your institution who is actually directly affiliated or directly in control, the easiest thing to do is to say no, or to refer the request to a compliance officer or a privacy officer, and it goes to the bottom of the stack and then of things to do, and then and you may get through the system, but the transaction costs of putting together a system like that are quite high. So the other barrier, aside from that phenomenon of what happens when there is an incredibly oppressive system of regulation, the other part of this that is difficult is that a learning health system is doing actually two different things. If one came from Mars, one wouldn't necessarily think that these things should be two different things, but the two different things are QA, QI on the one hand and research on the other. And for the purpose of our own regulations and laws and practices within the U.S., there is which is different in some ways than the way that this issue is approached in some other national jurisdictions outside the U.S. For better or worse, we have two different sets of rules. And even though the activities may look like they're the same. So when one has a learning health system, the purpose of it can certainly be to improve care immediately, to change standards of practice or clinical pathways within an institution or a set of institutions. But one might also try to generalize the knowledge and publish the knowledge and make it more generalizable to even more institutions that are outside of that particular healthcare learning system. When that happens, then one has what are, under our federal regulations, the so-called Common Rule, 45 CFR 46, which is enforced largely by OHRP, but also by any of the other institutions, the other government agencies that ascribe to the Common Rule, which is 19 other agencies. And DoD, as I understand it, has a form of not exactly the Common Rule, but a form of the Common Rule. Then when it's generalizable, then it falls under these research regulations. When it's QA and QI, it falls under either HIPAA and or state regulations governing mental health care, rehabilitation services, and other things, which still exist in parallel to HIPAA. And so when one is trying to merge data sets, not only historically, retrospectively, but also in real time and prospectively in order to develop the most useful learning system, and the more data, as you guys know, and have talked about extensively, the more data, the better for these purposes. Then one has to define whether what one is doing is either QA, QI, or research, or both. And if it's both, and in all likelihood you want it to be both because you want to maximize your ability to use the data in as many different ways as possible, then you're going to have to meet the requirements of both systems, both the QA, QI, confidentiality, privacy problems, or regulations, as well as the research ones. So it's not impossible, but again, it's the transaction costs can be high. The transaction costs have been criticized. They were criticized in 2009 by the IOM committee on HIPAA that was led by Bernie Lowe. They were criticized somewhat by the IOM committee that was led by Mark Smith in 2012 on learning health systems. So this is not the first discovery of these problems. But and we can get into, the extent that you're interested in the Q&A session, we can get into some of the peculiar kinds of legal challenges in both QA, QI, and in research. But suffice it to say that it means the following things, just in summary. And then, as I said, we can, if you have questions and you want to know more about it, I can certainly talk about it in the Q&A. It means that on the front end, in the just to give you the bottom line, in the notice of privacy practices that's given to individuals when they enter a system of care, when they're first when they're first admitted, either as an outpatient or an inpatient, they need to be told about a learning health system, and that needs to be described in the notice of privacy practices. In a research consent, for people who are entering a primary clinical study, it means having a sufficiently robust description of what is of what kinds of research will be done later with the banked data, and by the way, banked biospecimens in the case of other kinds of downstream research. There needs to be a robust consent that allows for that as well. And there are peculiarities about the way in which that has to be asked. So then, in regard to the actual practice, what it means for a learning health system for the QA/QI system is there are a couple of options. One is to engage a central party to be the so-called business associate of the hospital or healthcare provider that wants to participate in the learning system. That entity can then aggregate data from lots of entities that have bound it with a so-called business associate agreement. And it can perform data aggregation analysis and then give the analyses in real time back to these various institutions. On the research side, and then there's also a so-called limited data set option. And then on the research side, then what one has to do on the research side essentially is you either have to consent patients up front, like the BioView system does at Vanderbilt. Everybody who enters the Vanderbilt system and is offered enrollment in real time for the prospective collection and future use of all of their data and biospecimens collected as standard of care, and they get about a 99.5% compliance rate with that. So you can either do that, or if you're looking retrospectively, you can try to go to an IRB and seek a so-called waiver of informed consent and a waiver of HIPAA authorization. But what that means is when you have many different institutions in a healthcare system, it means that you've got to approach each one of them and get that kind of permission. And hopefully what they might do eventually is resort to a so-called central IRB or independent IRB, and all say that that one IRB can have jurisdiction for this purpose, but there are many institutions that for their own jurisdictional purposes don't want to do that. So I'll stop there, but that is sort of that's the bedrock kind of basics, foundation stones of what one has to look at in building a learning health system in a legal sense.
Well, thank you very much. It is now 2:11. We're supposed to go with our discussion to about 2:45, but started 10 minutes late. I'm saying we'll cut the difference and we'll go 5 minutes, so we can go up to about 2:50 with this panel. To start off with the discussion and questions, I was going to request on the committee, we have an expert in data management, and I was going to ask Dr. James to start.
I've got a series of questions. I heard both the civilian system and the military system say that you're using primarily abstraction to extract data from the medical record. You probably do things like iterative reliabilities. I'm not looking for that. How do you assess the quality of your abstraction? Other systems have found as high as 20 to 40% error rates with abstraction from a medical record, for example. Do you assess that, and how do you assess it? How do you make sure that what you're getting from the record accurately represents what really happens to the patient?
So we have a Thursday call where we review the cases as they move through the continuum of care, and our nurses sit in on that. And our physicians review a lot of the records through either the research they're doing or as we review the performance.
So the physicians and nurses who deliver the care review the abstraction to say that it is correct?
The physicians that have been involved in the care will provide a report back, and so we verify that when we're going through our abstractions. But it's not 100%.
On the civilian side?
The civilian side, we've been working on this for some time.
Can you turn on your microphone, please?
we've been trying to perfect this. You know, the labor costs associated with re-abstracting the data are considerable. We've now come to a process where 5% of charts are re-abstracted by our own people at the college. So they will.
That's inter-rater reliability is what you're doing.
That's right, but exactly. But you can do inter-rater reliability with 2 abstractors at the same site as well. So we try to externally validate with a different group of abstractors.
Yeah.
And from a trauma center perspective, as a medical director at University Health System in San Antonio, we actually do the same thing. It's sort of the standard practice would be a 10% audit of your available registry input. It becomes a challenge even in the civilian environment with respect to resourcing the people that are going to do those audits and analysis.
Well, I understand. The trick is there's another layer where you actually have the clinicians who delivered the care review the abstraction back, and when that occurs, you find some extremely high error rates occasionally, and so it's just good to check to see how you're looking at that to make sure you have accurate data. A more important question, how do you pick the data elements that you abstract? What was your process for selecting the data elements you abstract from the record?
Sure. So for the military side, we had a group of subject matter experts come together, and we had different services represented, and we reviewed the best practices on the civilian side with the American College of Surgeons, Pennsylvania Trauma Systems Foundation, all those groups, and used the best practices. And then we looked at the evidence in the literature to see where there were holes. So we didn't have a lot of blood data, so we put in a lot of blood components into our registry.
And we likewise went to several level 1 trauma centers and got their admission intake forms, and really went through each of those to define the commonalities that we wanted to include, and also added additional elements that we thought either would be salient to the battlefield environment now or in the future.
When you're talking about improvement work, it nearly always centers around workflow level processes of care. Have you gone through a formal method to identify your workflow level processes of care? So could you describe to me the method by which you identified those processes?
So one of the things that we do utilize besides that worldwide conference that we spoke about is that we have metrics built into our clinical practice guidelines, and those are continuously reviewed, and then we do educational seminars every week on our findings.
I really like that you're linking it to your clinical practice guidelines, and the reason is many good guidelines actually work at a workflow level. So there are 2 main ways of deploying guidelines. One way is to educate the health professionals and expect them to apply them from memory. This is an area where Beth McGlynn, for example, has shown about 50% reliability. In complex systems, even with highly trained people, deeply dedicated, they can't execute consistently. How do you deploy your guidelines into workflows so that it doesn't rely on human memory? The reason I ask is it ties directly to your data systems.
Part of the problem that we have is that the clinical practice guidelines are not required for use. And so they're not in doctrine, and they're not in the educational forms the way we would like them to be. So we have a huge gap there that we need to address. But we publish them widely. We're going to be publishing in the military medicine publication in the next 12 months, all our clinical practice guidelines. So we're trying to socialize them as much as possible, but there's nothing anchored in doctrine or requirement at this time.
But currently it's a purely educational activity is what you're telling me.
Yes. Yes, sir.
So in the clinical arena, in certain areas, we've developed documents or other materials that can be used at the bedside, checklists and so on, that ensure that the care is being provided according to guidelines, or at least they're reminders to ensure that the care is being provided to guidelines. Having said that, there isn't much at the bedside level that providers would typically use to ensure they're following the rules, if you will. There's a new product that I've seen called T6 Health Systems. This is actually a means of capturing data during the trauma resuscitation phase, which actually has reminders built in to ensure that docs are following the guidelines when they're providing care at the bedside.
Have you linked that to your data systems at all?
No, we're considering how that might be possible.
Okay.
So also I think that the example of the clinical practice guidelines is really a prime example of the iterative learning nature of the system. First developed to put an evidence-based resource on the battlefield, and then within the last couple of years, we've had the data and the analytical capacity to put in that tracking element where we can not only track outcomes of the clinical practice guideline, but many of the clinical practice guidelines, we can actually track compliance.
See, that's perfect, and that's how you start to link your registry systems into your EMRs so that they link together tightly. But it has to happen at a workflow level. And as soon as I say workflow level, it means they have to be organized around processes of care. And my guess is, it's been 30 years, 40 years since I was in general surgical training and doing a little trauma on the side. But what I know is nearly always you can identify usually a relative handful, 10, 20 processes that make up the bulk of the care. And so that's what I'm really looking for, is it organized?
The biggest liability, as Ms. Spott mentioned, is it's not a requirement.
So we work with our experts to identify quality indicators. We build those indicators into the registries, and that allows us to at least measure whether people are adhering to guidelines. It doesn't help them at the bedside, but those change. We've been focusing on, as an example, time to fracture fixation, and working with the experts. Say, well, don't focus on that anymore. It's not relevant. And we've just moved 300 hospitals to capturing that data. Now it's not that relevant anymore. So this is a very dynamic process.
What you're describing is what Jerry O'Connor at Dartmouth calls recreational data collection. When you rely upon experts to identify elements in a data system, they will speculate about what might be useful in a research setting. But when you're running outcomes tracking data systems, integrated data systems, you don't want to track what might be useful. You study that as a special project. Stuff that you routinely track is the stuff that you know are useful. Data are way too expensive and difficult to track them speculatively. Mm-hmm. So you have two forms. One is your built-in outcomes tracking piece. Then you have a little research piece off to the side, fast, easy to test is the idea. And so I was really trying to figure out if you were designed that way in your systems.
Well, there's an interesting process that occurs during the consensus development of fields, and there's always, it'd be nice to collect, and you look back over time and say, okay, we've collected that now, and it's had no value. And we try to go through the process of actually discarding fields from time to time, because I think at the center level, they just accumulate, and there's more and more data collection burden over time as a result of no one cleaning things up every once in a while.
Thank you very much, Dr. James. Just to make one point, there is one commonly used thing for clinical decision support, which is regarding VTE prophylaxis. Many centers have been able to use EPIC to use that to look at a process measure as they're providing care. So that is one thing that's being used. So we'll go next to Rita, then John Holcomb.
Thanks for the presentations, and I just was struck that there's a lot of challenges to data entry, both on military and civilian side, and that I commend you, for getting the registry online and starting, because in cardiology, I'm a cardiologist, we've had the National Cardiovascular Data Registry for some time, but we have all those same issues. It's said a 10% audit rate, but it's on very few fields, and it's not reliable, and there's always the challenge of how to fund it. And unfortunately, as Brent was pointing out, the registry is only as good as the weakest link. And I know, for example, for the ICD registry, to me it's very striking. We have these incredibly expensive devices. We spend millions of dollars on them, but nobody wants to pay, the little bit it would cost to actually collect data. And certainly, as you were saying, we don't have post-discharge on the ICD. You really want to know what happens when people leave the hospitals. The quality of life data is not being collected. CMS and FDA just passed the Transvalve Therapeutics Registry for the new transcatheter aortic valve, and they're supposed to collect quality of life data, but I hear from CMS that field has been missing, and nobody wants to collect it. So I think we have made progress, but certainly we're all seeing those same issues, and they are important ones to grapple with. Just with the clinical decision support, I have to say that, I've been seeing, more and more EPIC, and we're using it certainly at UCSF. You can put those support rules in the guidelines, but it's very, they're not really tailored to every individual patient. People have ways around them, and I see, people get good at coding what they're doing, but I'm not sure that it's really changing our practice and making our practice any better. When I see the support rules put into the record, I think what might happen is more changes in coding than actual changes in practice, just because it hasn't really changed culture or the way we do things very much. And as I think Brendan was talking about in the earlier session, in a fee-for-service system, our incentives are often not aligned towards best quality and best practices. My question, though, and I guess when you started out, you said that it was hard to, hang on, I wrote it. What were the barriers to sharing with your civilian colleagues? Because I think it's something we all sort of struggle with, is how to share the data. As I think at NCDR we have the same issues, and I'm just wondering what you see are the barriers and how we could move forward.
Sure. Because of the sensitive nature of the registry data, it often will reveal how well the device injured the military member. So, other sensitive information that we don't want necessarily out in the community unless there's oversight. And ensuring oversight is very difficult. We want to be very transparent and work with our civilian partners. We've been having several discussions with our legal teams on how to best do that, because they see the value of the data that we have. It's a protection issue for our service members, and that's really the biggest thing right now. I think the business associates agreements and all that are fine. It's just protecting the members to make sure that the operational issues aren't revealed as well.
Those seem like additional unique challenges.
Thank you very much. So we have about 6 committee members who want to get questions, and I'm going to ask if you could spend a minute at max on your question and then 3 minutes for the answer.
Hi. In both the military and civilian side, you bemoan the fact that your registry is not enriched by rehabilitation information and long-term outcomes, and you explain all the reasons why that's very expensive and very difficult. I wanted to ask, are the barriers to getting information from the VA healthcare system into the registry on the military side, can they be overcome? I know that's somewhat embarrassing and ugly turf for a lot of us, but they're 2 top-down organizations. Can the VA information system about rehabilitation and long-term outcome, can that barrier be overcome?
Sir, I think so, and I view it in a very simplistic fashion. If I could just get some VA abstractors and give them access to the registry, and they could port data and abstract data, that's the simplest way. In my mind, I don't see it to be a very difficult, complicated issue.
But it doesn't happen? It
doesn't happen.
I'm asking why it doesn't happen.
I think it's just, again, the business associates agreements and the protections and those types of things. It's just, and it's never been to a point where it's had to be addressed so urgently as before.
This has been something that was raised before. Colonel Eastridge, can you talk about the political issues around doing this?
All I can say is there are political challenges that are way above my pay grade to describe. And again, it's intimately related to the problem. From a boots on the ground perspective, Ms. Spot can hire abstractors tomorrow, and we know the sites where our combat casualties go. But the access is at a higher level of leadership, and the cooperation just isn't there to allow it to happen.
Sad, embarrassing. Yeah.
And Dr. Hogan?
So, one, Dr. Eastridge, I understand you're here on your 15th wedding anniversary. Thank you for your dedication and
Earning
service.
big points today.
Yeah. Your dedication to service continues, sir. Now that was easy. So, along those same lines, with the VA, orthopedics, neurosurgery, ophthalmology, infectious disease, all the special, are they putting all of their data into the JTR, or are they keep creating separate registries?
Currently, each of the centers of excellence are developing their own registries. However, the integrated registry system that we've built, we have infectious disease online, orthopedics, hearing is also starting. They have about 600 cases in, but the others are intending to develop their own systems.
I can actually speak to that also. Each of these individual specific subspecialties that are trying to develop their own registry, they're looking for a granularity of clinical detail that's beyond the scope of the current DoD TR. And what that means is it's just to field and fund one of these linked specialty registries is a resource challenge, almost akin to what it costs Ms. Spot to run the DoD TR.
And I think the other challenge has been that they're starting backward. So the system that we have built automatically has the same platform for IT infrastructure, the same data definitions, the same data element names and so forth. So everything's the same across all of the registries. And right now, the ones that they're building they're not planning to integrate until the back end. So everybody's developing them independently on different systems with different data definitions.
Sounds like an opportunity to collaborate a little bit more.
Yes,
Dr. Nathans, in TQIP, if there's a best practice identified in your risk-adjusted system, how do you share that with other institutions?
So we typically publish it, and we share it at our annual meetings. We share it on our webinars. So that's the typical process by which we communicate information. We haven't developed a coaching mechanism. Again, this is something that's been highly evolved through Hopkins and sort of related to what NISQIP does, where you actually work very closely with the centers who are having problems and coach them along to make sure they're following the best practices, understanding how they collect the data, how they should be collecting the data, how they're delivering care. We don't have that yet. We need to do that. David?
So I just want to put a military foot stomp on Dr. Parrish's comment. I don't think it's just embarrassing that DoD and VA data systems don't connect. I think it's negligent. So, Marianne, it's good to see you, and you were incredibly transparent with your, hey, here are some of the challenges of the JTS. In that, one of the things you identified that you collect data outside of the EHR. In essence, you're reliant on a provider to not only enter what he did through an electronic health system, but then step outside and someone else is collecting that independently, and that those data forms are then submitted to the JTS through different data streams, either paper, hard, mostly paper copy, correct?
Yes, sir.
Why isn't it that the JTS is looking at it from a soup to nuts standpoint and a more streamlined approach? Because the providers that we know who are taking a knee or doing the job or cutting the chest, they're task saturated. So can the JTS also think about adopting and including some of the data sets that are included within the AHR to make data more complete in addition to the way you're collecting it now? And I have one follow-on.
Mm-hmm. It's a yes and a no. So the yes part is, there's certain data points like demographics and things that are very reliable data. The other data are interpretable data. So if I'm looking at a complication, it's, how many, what was the colonization for pneumonia or something like that, not just documented by a physician. So those things are more interpretive, more difficult to do. One of our colleagues started a registry, and they tried doing exactly what you mentioned, and they had an 80% error rate in the data that they had come back. They used even natural language selection for some of the discrete data points they were filling in. So we have found, or in my opinion have found that, in my experience, is that the registrars do a much better job than the IT tools that are currently available. The unfortunate thing is that the IT people are running the show and not the clinicians. And so the data that we're getting is important for the information system, but not necessarily the clinician. And when we go to abstract it, our abstractors aren't the physicians. Our abstractors are the nurses that are attending the resuscitations in theater. So there's not dual data entry, there's not dual documentation, and that allows us to have near real-time PI, and that makes our registry much better and our performance and our outcomes much better.
Thanks.
When those registrars go away, such as now, then the data has to come back to the shop here in San Antonio, and there's something lost in that translation piece too. So we lose data by not having boots on the ground to abstract it.
And we don't have our physicians right there that can work with our nurse during the resuscitation where they can discuss the case and collect the information.
Got it. And I think it's interesting how those data streams that you're collecting are kind of still stovepiped, and there's not a linkage even within we're talking about DOD and VA speaking, but even within JTS, you're collecting what happens in the pre-hospital sector independent from what happens in a Roll 2 versus what happens in, so they are still stovepiped. A question around that, and Colonel Eastridge, it's good to be in the room with you. Your name carries a lot of weight within this community particularly around trauma delivery of care. Tell me how the JTS data informs planning. Tell me how planners who are Air Force, we heard from the leadership that this is a joint approach. This is joint operations, and it was mentioned multiple different times. It was a purple effort. Tell me how within PACOM right now, within AFRICOM right now, what is happening to not only influence how we provide better care within the surgical suite, but how that's informing a system of care and how the JTS data helps inform that system so we have better outcomes.
Yeah, that's a great question. So again, alluding to the iterative process, early on in the conceptualization and building of the JTS, we developed basically it was a user-defined standard report with the medical commanders on the battlefield at that time of what's important to them with respect to medical data at their level and what they perceived at a higher level. Fielding that. And also in the sort of nascence of the process, Dr. Holcomb brought the CENTCOM surgeon into the process. Having that COCOM surgeon as our advocate to promulgate the JTS was absolutely invaluable. That went to the level of the Joint Staff Surgeon, and then subsequently developed because on top of that to higher levels of medical and line command. In addition, from the perspective of our transparency, our conferences initially started off as solely clinical conferences, but the two conferences that we had a week were rapidly joined by folks in the logistics and planning community to better inform their material acquisition, to better inform their medical planning, for the sort of the force laydown and medical, more specifically for the medical planning to support the force laydown. So not a formal process, but again an iterative process predicated upon the fact that we had the data for use by anybody with a need to know.
And I think another point to mention is that when you mentioned stovepipe, there's no requirement to send the data, so it's a coalition of the willing. So it's people that come to us and say, we want to send you our data. How do we do that? And we send them the disks and provide over computer training and stuff like that. But there's no requirement to even send it to us.
Next, Sarah.
So I have a few questions primarily directed to Mr. Barnes, but others may want to weigh in. I guess the first question I have is, do you see any creative ways of surmounting some of the barriers associated with HIPAA and other privacy and confidentiality issues? And so one of the things that I'm thinking about is, at least within the military setting, perhaps what you could do is get a HIPAA authorization when someone joins the service. And that could just remain a part of their record for a period of time until it's, I guess, invalidated legally. But there's a sense of, it's the aims of what's being done with the DoD trauma registry are clear. So couldn't that be described from the outset, and that could just sort of be a standing authorization? Now, that would be a less optimal approach for the civilian sector, since it would be sort of hit or miss who's going to end up being part of the trauma care system. But can you think of ways that we could comply with, but in a creative sort of streamlined fashion with the requirements of HIPAA? And that's my first question.
Well, one thing about you know, the military setting is that would someone actually have a choice not to sign the HIPAA authorization? Because the way that that HIPAA is constructed is really is not as a command and control mechanism. It really is it's important that the authorization not be conditioned upon receipt of anything. So in this case, you know, if one conditioned, I mean, one might be able to condition entry into the military on that, but it may take either a change in regulation or it may take even a statutory act. I don't know what would happen with that. But if you could do that, then if you could get everyone to sign up and to sign an authorization, then what you could do affirmatively is that it would not, the purpose for that would not be to be able to share information within the military providers. That you can do anyway as part of regular healthcare operations. What that would do is it would allow you to pull the data from all the other providers that are not part of that particular DoD of the DoD healthcare network, and that would include the VA, by the way. So one could, in that sense, get the community mental health information, the private rehab hospital information after discharge. One could get all of that stuff if one could do that up front. You know, the other way of doing it would be, I guess, frankly, that's one possibility. I mean, there are other possibilities and you know, there are groups that are thinking about this. There's an organized group that Tony Asher from the neurologic surgery has put together that the ACS is involved in, and the cardiology board is involved in as well, trying to amend some of the persuade the agencies to amend some of the guidance to try to ease the transaction cost of doing this. But I mean, another way to do it would be to provide some kind of financial incentive for other private providers or public providers that are outside DoD to participate. But that would involve either money or some kind of service. And I can imagine that the kind of service that you could and how this often works in terms of giving a benefit back to the entities that give you data, is to give them access to the findings and to the care pathways and that sort of thing, because they will often participate in care networks and they will donate data if they can actually get something back in kind for donating their data or allowing the use of their data. So that's I think the answer to your question. But there's no perfect way of doing it. On the other hand, Vanderbilt gets in a civilian population gets a 99.5% acceptance rate. I mean, that's under a population that is, in Middle Tennessee that's quite compliant, and maybe that wouldn't happen in Boston, but it is possible.
Just in passing, I chaired the group who put this together for Intermountain, and we put it into our informed consents that all patients sign when they enter the system, made it an opt-out basically, and presented that to SATCORP at least one day with Dawn, and it was acceptable to them. So there are ways of working around that.
And then I'll just, in the interest of time, restrict myself to one more question. So let's just say you're in the process of doing what you think is a quality assurance, quality improvement activity, and you didn't go through getting informed consent or having informed consent waived through an institutional review board, and you realize that you're learning information that really would be helpful to share and it is generalizable. Do you have thoughts on how to handle that scenario?
Yeah, I mean, that's the $20,000 question in the line between QI and research. I mean, what I have said operationally when I've been the institutional official at various institutions is, including St. Jude and Harvard, is I've said if you're doing that and it comes to the point that you actually think that you're doing research, then stop what you're doing and develop a protocol, call the IRB administrator or the IRB chair and develop a protocol and get waiver of informed consent for it. There's really no other way to do it. I mean, the more a kind of rigorous answer is that you can't do it. But that's never satisfied me, because there are many times, I mean, just in the way that people work and the way that they work with their data, you develop hypotheses in the middle of trying to figure out some administrative problem, or in this case, a clinical pathway problem. And I think that we're only hurting ourselves as we shut down the possibility of converting QI to research. With that said, I mean, the better way to do it is to think from the beginning that what you might be doing when you do QI is that you're doing research and design your system so that it really complies with both regulatory regimes.
Thank you. We have about 6 minutes left and 3 committee members, so we'll go rapid fire, 2 minutes each. We'll go starting with Ellen.
So I roger the transmission that the trauma system is different than the trauma registry. But I'm interested in how the trauma registry or the trauma system is any different than any other kind of clinical process that is interested in understanding and creating a learning system. When you create a registry, you do so because it is different than the normal process, the routine process, the well-defined clinical care path, I guess, for normal diagnoses. But I can't imagine that the registry itself was created. I was there when it happened. And, John came in and said, we had to do this. And I said, okay. And can we all agree on common data? Can we do a single system? No, nobody could agree. So we just said, okay, we're going to do common data and common process, and that's it. Everything else is, we'll figure it out later. But we knew that this would be used for research. We knew it would be used for QI, but we didn't go through the consent. We didn't do that. So, which is why they're not connected to the EHR, right? So the question I ask is, are we bound by the traditional data requirements for a use case when we have a registry? And should we tie that registry to some data utilization plan that's tied to the care path?
Those are great questions, and we're working with our attorneys right now to answer some of those questions. When we separated out the difference between the performance improvement and the research, certainly the QI can lead to research, but we pretty much draw a firm line and say that we're not using our registry for the sole purpose of that. It's a continuous care. There are some other financial issues with research versus PI, but you bring up a great point that I think we have to look at to make sure that we're covering our bases appropriately, because that is a huge question for us right now.
Just a quick follow-on. It does seem to me that the registry, when it was stood up, was very insightful in identifying the full continuum of care and recognizing that we had a limited electronic health record, if you will, and this was a single opportunity that we didn't want to lose during the wartime. We wanted to capture this information so that we could learn from it. That was a clear message that I understood.
Yes.
Now we are 10 years ahead, more than that really. What do we learn from that process that we can translate now into the civilian side? I think it's very important. We don't have good, we have the HIPAA challenges, we have mechanisms around which to get pre-consent to cover all bases ultimately, because if we truly are dedicated to a learning health system, we are going to want to do retrospective research, I assume. And so the question would be, now that the information technology systems are capable of putting structured and unstructured data together and associating data that never was intended to be associated, what should we be doing? How should we structure that continuum for the trauma system?
Maybe a one-sentence answer.
I think trending and a system approach, not just on the individual case basis.
Developing continuum of care data streams on the civilian side.
That's a good one-sentence answer. And perhaps a one-sentence question, Jory, and then Dr. Berwick.
Well, I think that the performance improvement process...
Microphone.
I think that the performance improvement process in the trauma registry is the backbone of a successful trauma program. And so with that said, there's a lot of things that we could do with the registry that we're not. If you want to look at overall accountability for the institution, and by that I mean length of stay, cost, mortality. So we do that to some degree with the site survey process, but we could probably do it better. In addition to that, the best practice can be integrated. So my question to you is, maybe Dr. Avery with the ACS, Dr. Eastridge, is there going to be a point in time when we look at this trauma system development that the trauma center's first level of review before the team ever comes to your hospital is to look at your TQIP data, your trauma registry data, look at outcomes, and then give you some feedback before they ever come? And then the second question I have is it possible to add additional data elements to look at a system component for the hospital and the system, the regional system, to actually measure performance in the region so you can identify when there is a need for additional trauma centers, or perhaps there is saturation of the trauma centers?
So both excellent questions. With respect to your first question, first of all, I agree that the data and the registry office within a center is probably the backbone of trauma PI and really the backbone of the center. And it's under-resourced typically. We know that the ratio of registrars to patient records is probably too low, and that needs to be addressed. So what are we doing? Currently, what we're doing from a TQIP perspective, we're working closely with verification so that now the reviewers, when they go visit a TQIP center, they will have components of the TQIP report with them. Part of that will also include the data quality. So that will provide the reviewers with a sense of how interested the center is in quality improvement. Without good data, if there's big data quality problems, there's likely quality of care issues. So that's being done. With respect to what you're saying is systems benchmarking, or at least systems assessment, there's been a lot of consideration about how we would go ahead and do this. So we have most of the level 1s and 2s on board. We have a level 3 pilot. It'd be nice to get a lot of the other centers as well, the smaller designated centers. The big challenge becomes understanding what the non-designated centers are who aren't contributing any data. And this is where you have to link, or at least bring in administrative data to understand who's getting care where and where there might be access problems. Once you identify where the access problems are, you can get a better sense of how patients move through the system and whether there's additional need for more centers or whether you have too many centers.
Thank you, Dr. Nathans. In the interest of time, we'll go to the last very short question from Dr. Berwick.
I'll withdraw.
Well, thank you very much for coming to Washington for this very important session. Your insights have been very useful to the committee. Thank you so much.
Thank you all. That was fantastic. We're going to move on to another session.